All right, so I'm going to be presenting findings from an international partnership which has been looking at the evidence and evidence gaps on ethnic and religious minority group inclusion in public services. Steve Oomer, who's mentioned here, was going to present a poster at the conference, but unfortunately he couldn't make it. But I've got some printouts of his conference, which are about the findings in Kenya, if anybody would like to take those. What I'm going to be talking about is the global review that we did as part of this partnership work. So the background is that globally we know there's already evidence that people from minority ethnic and religious groups face exclusion, the highest levels of exclusion often, and disproportionately represented, for example, in slum dwellers or in deprived areas. And during times of rapid economic growth, they're often left behind so that the inequalities that they experience become ever wider. Within those populations, there are also people who face additional layers of disadvantage, what we call intersectional disadvantage, relating to gender, age, and migration, as well as poverty. And public services are often a mechanism through which the disadvantage that people experience is created and maintained. So our research questions were, could these same public services actually become mechanisms for inclusion, and how could research help to make that happen? So as I said, we had a 5-country partnership. The UK was looking at the evidence from a global perspective, and then we had 4 country-specific reports looking at the issues within these particular contexts. We're a multi-sector partnership in that we had, apart from academics, we had policymakers and practitioners, non-governmental organisations, so voluntary sector organisations, and we looked at 4 public service areas. So apart from healthcare, we were looking at public services that might link with the determinants of health, so education, local government and police services. And we had people from different disciplines involved in the network, so political scientists, health service researchers and various other disciplines. And we were very solution focused within this network, which was called the Socially Inclusive Cities Network. We looked at the evidence both in the literature, and we were looking for strategies for inclusion that public services might have used within these 4 areas of public service. On top of the literature review, we also held national and international workshops to try and bring the evidence together and to find out what was happening in policy, practice and within the voluntary sector. We produced various different reports looking at the drivers of exclusion, what strategies had been developed to address those drivers, and also what the future research was needed to fill the gaps that we'd identified, and also a separate sort of report looking at intersectional disadvantage. So there were some concepts that it was important for us to really lay out, and some challenges that we came across. We defined inclusion as equitable and comparable access to services, representation in services, and outcomes from these services. And we identified exclusion as denial of a human right. We also thought of ethnicity as a fluid and dynamic concept, similar to the research that has been done globally, recognising that in some areas, like Nigeria, for example, whether you're part of a disadvantaged or a privileged group can have a geographical element. Moving from one part of the country to another can actually change your social status in terms of ethnic advantage or disadvantage. In some contexts, such as Vietnam, religious identity is not recognised at state level. So having needs that are related to your religious identity can be completely ignored in those contexts. And even in the UK, even though we sometimes find very stark examples of discrimination in low and middle income countries, a lot of them resonated with things that we know happen in the UK too. So religious identity doesn't really receive a lot of attention, and actually there can be quite hostile reactions to religious identity in the UK context too. But within low and middle income countries, we found that there was really a lack of research. Most of the evidence came from the US and from Western contexts. So there's a lot more that needs to be done in terms of research for those particular areas. We developed this model which looked at the sort of different levels at which discrimination and exclusion can happen. Somebody talked about the political context, the kind of cultural norms within a society. And at that socioeconomic and political context, people can be excluded through competition for resources and through power imbalances. That can impact on institutional dynamics so that people's needs are not met if they're from these particular groups, and they face barriers to service provision and consequently worse outcomes. And those dynamics within different kind of public services can lead to and feed into lower literacy levels, mistrust and fear of services, which again, this is a kind of a self-sustaining dynamic. So these different drivers are actually reinforcing each other. And what we did was map the different strategies for inclusion that we found to these different levels of exclusion to see how well they matched the kind of dynamics that we had identified. And what we found was that it was very rare for interventions to actually address all three levels at the same time. And it was very rare for interventions to work across the different determinants of health to encourage cross-agency work. So the gaps that we identified are three key themes. First was actually understanding how things could change is a key area for research. We don't really understand enough about how negative understandings of minority ethnic and religious groups can be countered in public services. We often get the arguments that blame communities for their own exclusion, and we don't really know enough about how we can change those kind of dynamics within public services. We also don't know enough about how to measure inclusion and exclusion. And if you see this quotation from one of the residents of the Makoko slum in Nigeria, it's clear that for people from these communities, practical, concrete outcomes in terms of inclusion, looking at people who are employed, affordable housing, sanitation, these are the kind of things that make a difference to them and should be taken into account in terms of the measures that are used. A second theme was this whole idea of working across agencies and at different levels. And what we tried to do was really reflect the complexity of how people experience exclusion in their lives. If we just look at this from the point of view of healthcare, for example, it doesn't take into account the fact that there's simultaneous disadvantage being experienced in other areas of people's lives that all feeds into those inequalities in health. So we need to know more about how services can work together to reflect that complexity and to try and address it in terms of what interventions can be successful. And the kind of all-stakeholder collaboration that we're promoting within our future research agenda requires a lot of skill in terms of leadership, cultural understanding of the social and political context, and using participatory models of involvement so that people who are excluded from decision-making actually have a voice. But how do we actually understand what are the barriers and facilitators of that kind of design, research design? And thirdly, somebody mentioned in the first session today the political context and how do we influence policy development or even policy implementation. Sometimes the policies are already there, but they're just not being implemented. How can we really try to make services more receptive to voices that are often excluded? And again, you can see in this quote from the Makoko slum again, nepotism is a key issue in many contexts. And profiting from dysfunctional health systems. It's something that we talk about actually in terms of the privatisation of the NHS here in the UK. So this is not something that is just confined to low and middle income countries. We actually need to think about these issues at a global level, although the manifestations may be different in different contexts. And in terms of people who are working on research, some of the studies that we looked at, many of them did not really have very robust design. So thinking about how to define people from these populations, there's often vague definitions that they're not consistent across different studies. Methods are not comparable so that you can't actually do meta-analyses often because of the different approaches that have been used and different measures. The baseline for improvement is often not clear and the evaluation is not robust or rigorous enough. We need more objective measures of effectiveness and we need to pay more attention to impact and to things like cost effectiveness, which will influence commissioners. 4 key areas for people working in research to think about in terms of how this kind of research should be conducted. We need to be modelling inclusion within the research process. If we have research teams that are not representative of the communities that we're working with, then we're not going to get very deep into the kind of issues that we need to be looking at. And privileging those voices that actually have been excluded for so long and that need to, in order to rebalance the discussion and the narrative, we need to actually give them more weight and to give them more privilege. to sort of disrupt the current narratives. That can come through representation at all stages of the process in terms of defining the research, including defining the research question. And we need research teams that have skilled members who can link to social networks in these communities and work on issues relating to co-production, so that we frame research questions and research design in ways that actually address the priorities of people from these populations, and we introduce an element of accountability for researchers to the people that we're working with. So that's all I'm going to say about the project. I've got 2 minutes left, but I actually have probably timed it to a bit less than I was given, but hopefully that gives more time for questions. Thank you.